Slide 1. This slide tape is one of a series of presentations in renal pathophysiology prepared by the American Physiological Society. 2. The program begins with a review of prerequisite knowledge. Before you go any further, make sure you have completed the entry skills test provided in the study guide. 3. During the presentation, question slides will appear at intervals. Stop the tape to answer the question. Then, advance to the next slide on which the answer will appear. Stop the tape again to check your answer. After you finish the unit, assess your understanding of the material by taking the post-test in the study guide. 4. The subject of this discussion is metabolic acidosis. Content expert, Dr. Howard Bleich. 5. The following presentation, first, discusses the criteria which determine the presence of metabolic acidosis. Second, identifies the causes. And third, indicates methods for treatment. 6. Our first major objective is to identify the presence of metabolic acidosis based on 1. The relationship between bicarbonate concentration and carbon dioxide tension in the blood, and 2. The plasma concentration of unspecified anions. 7. At the end of the first section, you should be able to 1. Define metabolic acidosis. 2. Name the compensatory mechanisms for metabolic acidosis and respiratory disturbances. And 3. Draw and label graphs for metabolic acidosis with superimposed respiratory disturbances and for respiratory disturbance with superimposed metabolic acidosis. 8. This equation depicts the relationship among dissolved carbon dioxide gas, carbonic acid, and bicarbonate concentration in the plasma. Since the concentration of water is constant, the concentrations of carbon dioxide gas and carbonic acid rise and fall together. That is, they are proportional to one another. It is customary for clinicians to think about carbon dioxide tension and carbonic acid concentration interchangeably. 9. The normal carbon dioxide tension is set by respiratory control mechanisms at 40 millimeters of mercury, which corresponds to a carbonic acid concentration of 1.2 milliequivalents per liter. The normal plasma bicarbonate concentration is approximately 25 milliequivalents per liter. Hence, the ratio of bicarbonate to carbonic acid is approximately 20 to 1. 10. The hydrogen ion concentration in the extracellular fluid must remain at approximately 10 to the minus 4 milliequivalents per liter. That is, several magnitudes less compared to other solutes. 11. Since the hydrogen ion concentration is so small, whenever several milliequivalents are added to the extracellular fluid, the hydrogen ion promptly combines with bicarbonate to avert an acid-base disaster. 12. Similarly, when hydrogen ion is removed from body fluids, it releases bicarbonate ions, increasing their concentration. 13. Normally, metabolic processes add hydrogen ion to the body fluids at the same rate at which the kidneys remove it, with the result that bicarbonate concentration remains constant and the ratio of bicarbonate to carbonic acid is maintained at its normal value of 20 to 1. 14. When hydrogen is added to the body fluids faster than it can be removed, the result is a condition called metabolic acidosis. The bicarbonate concentration decreases, and the ratio of bicarbonate to carbonic acid falls below the normal value of 20 to 1. 15. The physiological compensatory response to metabolic acidosis is to increase pulmonary ventilation, a maneuver that reduces carbon dioxide tension. 16. Once carbon dioxide tension has been reduced to 10 millimeters of mercury, no further reduction is possible. Additional muscular effort would generate carbon dioxide as fast as it could be removed. 17. For example, when additional hydrogen ion reduces bicarbonate concentration from 25 milliequivalents per liter to nearly zero, increased ventilation reduces carbon dioxide tension by 30 millimeters of mercury. In patients who ventilate appropriately in compensation for uncomplicated metabolic acidosis, there is a 1.2 to 1 relationship between carbon dioxide and bicarbonate. 18. When the patient fails to ventilate appropriately for the observed reduction in plasma bicarbonate concentration, a respiratory disturbance is superimposed on the metabolic acidosis. In this case, the patient with metabolic acidosis has a carbon dioxide tension significantly greater than that shown by the line that depicts appropriate compensation. 19. Respiratory disturbances can be identified by determining the relationship between PCO2 and bicarbonate concentration in the blood. When CO2 is generated by body tissues faster than it can be removed, the result is an excess of CO2 in the blood called hypercapnia. When a patient develops acute hypercapnia, the normal response is to remove hydrogen ion by hemoglobin and other body buffers within 10 minutes and to generate bicarbonate. As a result, in the patient with acute hypercapnia, plasma bicarbonate concentration is slightly increased. 20. After hypercapnia has been present for 3 days or longer, the kidneys excrete additional acid into the urine, thereby removing more hydrogen ion and generating more bicarbonate. As a result, in the patient with chronic hypercapnia, plasma bicarbonate concentration is further increased. This increase tends to restore the ratio of bicarbonate to carbonic acid closer to the normal value of 20 to 1. 21. When the kidneys fail to excrete additional acid into the urine, thereby removing hydrogen and generating bicarbonate, metabolic acidosis is superimposed on the respiratory disturbance. The presence of superimposed metabolic acidosis is established by the finding of a plasma bicarbonate concentration that is inappropriately low for a patient with respiratory insufficiency, that is, a failure to compensate appropriately for hypercapnia. 22. It should be emphasized that if a patient is known to have chronic hypercapnia, the finding of a bicarbonate concentration appropriate for that in acute hypercapnia provides convincing evidence of metabolic acidosis. For example, this patient is known to have chronic hypercapnia. A PCO2 of 60 millimeters of mercury implies a bicarbonate concentration of 35 milliequivalents per liter. The laboratory finding of bicarbonate concentration of 27 milliequivalents per liter provides evidence for the presence of metabolic acidosis superimposed on the chronic respiratory disturbance. 23. To recapitulate, metabolic acidosis results from a decrease in bicarbonate concentration in body fluids, which leads to a decrease in the ratio of bicarbonate to PCO2. When respiratory disease is superimposed on the metabolic disturbance, the PCO2 remains greater than expected for uncomplicated metabolic acidosis. Respiratory insufficiency results in hypercapnia, which leads to an increase in plasma bicarbonate. When metabolic acidosis is superimposed on the respiratory disturbance, the plasma concentration of bicarbonate remains lower than expected for a patient with respiratory insufficiency. 24. Remember to stop the tape to answer questions and to check your answers. 25. 26. 27. 28. 29. 30. At the end of this section, given the necessary data, you should be able to 1. Calculate the unspecified anion concentration, and 2. State whether or not the value is normal. 31. In addition to the evidence derived from the relationship of PCO2 and bicarbonate concentration in the plasma, metabolic acidosis can be inferred from the finding of an elevated plasma concentration of unspecified anions. The determination of these anions will be explained in the next several slides. 32. Here is the normal pattern of electrolytes in human serum. The sodium concentration is approximately 140 milliequivalents per liter, chloride 103 milliequivalents per liter, and bicarbonate 25 milliequivalents per liter, leaving approximately 12 milliequivalents per liter of unspecified anions consisting primarily of negative charges on protein, phosphate, sulfate, and organic ions. 33. By definition, the unspecified anion concentration is the difference between the concentration of sodium and that of chloride plus bicarbonate, normally 140 minus 128, or between 10 and 14 milliequivalents per liter. If serum potassium concentration has been measured, the anion concentration may be calculated more precisely. It is the difference between sodium plus potassium and chloride plus bicarbonate, or a range of perhaps 14 to 18 milliequivalents per liter. 34. If 10 milliequivalents per liter of hydrochloric acid is added to body fluids, the hydrogen ion combines with the bicarbonate and reduces the bicarbonate concentration from 25 to 15 milliequivalents per liter. The chloride concentration increases from 103 to 113 milliequivalents per liter. However, the unspecified anion concentration remains unchanged. 35. If hydrogen enters the body fluids with an anion other than chloride, the chloride concentration remains unchanged. The addition of hydrogen removes bicarbonate, and the unspecified anion concentration increases. 36. Although the finding of a normal or nearly normal plasma concentration of unspecified anions does not exclude the possibility of metabolic acidosis, for example in a patient ingesting ammonium chloride, the finding of an elevated concentration of unspecified anions provides convincing evidence that acidosis is present, and that the hydrogen ion entered the body fluids together with an unspecified anion. 37. 38. 39. Our second objective is to be able to identify the causes of metabolic acidosis in disturbances in which 1. Unspecified anion concentration is unchanged, and state the mechanism by which bicarbonate is lost, and 2. Those in which unspecified anion concentration is increased, and identify the anions added to body fluids. 40. The most common causes of metabolic acidosis that leave the unspecified anion concentration unchanged are severe diarrhea, renal tubular acidosis, carbonic anhydrase inhibition, ammonium chloride intake, and ureterosigmoidostomy. 41. Diarrhea can cause the loss of sodium bicarbonate, which, if replaced by dietary sodium chloride, in effect exchanges bicarbonate for chloride, and hence the unspecified anion concentration remains unchanged. 42. Renal tubular acidosis consists of an unexplained defect that inhibits the transport of hydrogen ion from blood to tubular fluid. As a result, some of the electrical forces generated by sodium reabsorption that would normally be neutralized by hydrogen excretion are now neutralized by chloride reabsorption and by the excretion of potassium. Retention of hydrogen decreases plasma bicarbonate concentration by about the same magnitude as increased chloride reabsorption increases plasma chloride concentration. Hence, the sum of the concentrations of bicarbonate plus chloride, and therefore the unspecified anion concentration, remains virtually unchanged. 43. Carbonic anhydrase is necessary for the hydration of carbon dioxide and for the formation of carbonic acid, from which hydrogen ion can be pumped into the tubular fluid. Carbonic anhydrase inhibition retards hydrogen excretion and thus mimics the effect seen in renal tubular acidosis. 44. When ammonium chloride is ingested, ammonia is removed by the liver and hydrochloric acid is released. Similarly, lysine hydrochloride and arginine hydrochloride may, once metabolized by the liver, cause metabolic acidosis. It is not likely, however, that these agents will cause metabolic acidosis, since they are usually given to treat metabolic alkalosis, or they are given in conjunction with diuretic therapy, which itself tends to produce metabolic alkalosis. 45. The acidosis that accompanies ureterosigmoidostomy is conglomeratic. Patients excrete ammonium into the lumen of the gastrointestinal tract, where a portion is reabsorbed as ammonium chloride. In addition, the electrolyte composition of fluid instilled into the colon contains significant quantities of bicarbonate, which is excreted. Also, patients frequently have ascending urinary tract infections or stenosis of the ureteral implants, which may impair renal excretion of acid. 46. 47. 48. Let us turn now to a consideration of the circumstance in which the unspecified anion concentration is increased, a circumstance in which metabolic acidosis is ordinarily present. The most likely causes of the metabolic acidosis are lactic acidosis, renal failure, diabetic ketoacidosis, or intoxication due to salicylate or methyl alcohol. 49. Lactic acidosis is frequently diagnosed by exclusion, although if special care is taken, it is possible to measure plasma lactate levels. Most patients with lactic acidosis are in shock, correction of which may correct the metabolic abnormality. In addition, however, lactic acidosis may occur spontaneously in patients with acute myocardial infarction, diabetes, leukemia, glycogen storage disease, and occasionally in totally fasting obese patients. In these patients, the disease is usually fatal despite correction of acidosis. 50. In renal failure, phosphate and sulfate constitute the principal unspecified anions. 51. In diabetic ketoacidosis, ketone bodies such as beta-hydroxybutyrate and acetoacetate are released. These constitute the additional unspecified anions found in the extracellular fluid. 52. In salicylate intoxication, the unspecified negative ions have not yet been identified, although salicylate, lactate, and pyruvate constitute a small portion of the increased unspecified anion concentration. 53. 54. 55. Our last objective is to indicate the treatment of metabolic acidosis by 1. Estimating the bicarbonate deficit, 2. Identifying and, if possible, removing the physiological disturbance, and 3. Deciding in which cases bicarbonate should be administered. 56. The bicarbonate deficit can be estimated by recalling that the volume of distribution of bicarbonate is approximately that of total body water, that is, approximately 60% of body weight. Thus, for a 70-kilogram patient, total body water equals 42 liters. If the patient has a plasma bicarbonate concentration of 5 milliequivalents per liter, that is, 20 milliequivalents per liter below normal, the deficit is 42 liters times 20 milliequivalents per liter, or 840 milliequivalents. 57. For the purpose of this calculation, it has been assumed that the volume of distribution of bicarbonate is essentially that of total body water. In fact, the intracellular space has lower bicarbonate concentration than does the extracellular fluid. 58. The intracellular space has cellular reactions that buffer the addition of acid, with the result that in patients with severe metabolic acidosis, the volume of distribution of bicarbonate, and hence the magnitude of the deficit, may actually exceed that given by the calculation. 59. The discrepancy is of little clinical relevance, since in the patient with severe metabolic acidosis and a concomitant bicarbonate deficit of 840 milliequivalents, administration of this quantity of sodium bicarbonate would impose an osmotic load of 1,680 milliosmoles. This is equivalent to the same load as 7 liters of isotonic saline and may be dangerous. 60. Administration of such a large amount of bicarbonate over a period of 1 to 2 hours would raise the plasma concentration immediately, but would not rapidly increase cerebrospinal fluid concentration. Recall that bicarbonate takes many hours or days to equilibrate with the cerebrospinal fluid. 61. When plasma bicarbonate concentration is restored to normal, the hyperventilation caused by metabolic acidosis is reduced. However, due to the continued presence of a bicarbonate deficit in the cerebrospinal fluid, some hyperventilation would persist. The result would be a severe, possibly fatal, respiratory alkalosis in the plasma. 62. Since the bicarbonate added to the plasma rapidly reduces hyperventilation and raises PCO2 all over the body, the cerebrospinal fluid, influenced by the higher carbon dioxide tension from reduced hyperventilation, would experience an even more severe metabolic acidosis. 63. 64. 65. Treatment of metabolic acidosis consists of determining the etiology and removing it if possible. In the patient with lactic acidosis, bicarbonate should be administered. Because of the unpredictable nature of acid metabolism in these patients, follow-up measurements after bicarbonate administration should probably be obtained in 1 hour. 66. Correction of metabolic acidosis by bicarbonate administration is not always desirable. If acidosis is due to renal failure, bicarbonate administration may cause hypocalcemic tetany, or the combination of gastric acid and orally administered sodium bicarbonate may produce sufficient carbon dioxide gas to promote burping and vomiting, and the resulting volume depletion may be particularly dangerous for a patient who is uremic. 67. If acidosis is due to diabetes, insulin administration will ordinarily eliminate overproduction of acetoacetate and beta-hydroxybutyrate. Metabolism of these circulating ketone bodies regenerates bicarbonate, which was removed when they were added to the extracellular fluid. 68. Treatment of salicylate and methyl alcohol intoxication will depend upon the symptoms. The acidosis can be corrected by bicarbonate administration. The other effects of intoxication call for different measures. 69. From your previous acid-base studies, recall that during the development of the acidosis, potassium comes out of the cells and is often excreted by the kidneys as fast as it is added to the extracellular fluid. As a result, the plasma potassium concentration remains normal. 70. Accordingly, the finding of a normal or even slightly elevated potassium concentration at the time of the first electrolyte determination does not exclude the possibility of a severe deficit of total body potassium. 71. During the correction of metabolic acidosis, potassium is returned to the cells in exchange for hydrogen which comes out of the cells. In the absence of anuria, the need to administer significant quantities of potassium during correction of the acidosis should be anticipated. 72. The dose of potassium cannot be calculated precisely, but must be estimated from repeated measurements of the serum potassium concentration. For example, when the extracellular fluid compartment contains 56 milliequivalents of potassium, the rate of intravenous potassium administration probably should not exceed 40 milliequivalents per hour, since time must be given for administered potassium to enter cells without significantly raising extracellular potassium concentration. 73. 74. 75. To summarize, metabolic acidosis is present when either hydrogen ion has been added to or bicarbonate ion has been removed from the body fluids. In either case, plasma bicarbonate concentration has been reduced. 76. A useful way to classify the cause of the metabolic acidosis is to examine the plasma concentration of unspecified anions. 77. Treatment of the metabolic acidosis consists of defining the etiology of the acidosis and removing it if possible. Then, using your knowledge of the behavior of the disorder, whose cause you have determined, and the severity of the bicarbonate deficit, consideration can be given to correcting a portion of the bicarbonate deficit, and a decision can be made concerning the interval of time that may safely elapse prior to repeated acid-base measurements. When treated in this way, most instances of metabolic acidosis can be adequately managed. 78. This concludes the discussion of metabolic acidosis. To assess your understanding of the material, take the post-test in your study guide.